Good morning, everyone. Thanks for joining us for our first Distinguished Guest Lecture series for the year. I'll get the ball rolling. So I'd like to thank everyone online and in person for attending today. And I'd like to introduce you to Professor Arthur Jeng. He is the Chief of the Division of Infectious Diseases and Director of the AMS program at Olive View UCLA Medical Center in California. He also serves as a clinical professor of medicine at the David Geffen School of Medicine at UCLA. He completed his undergraduate studies at the University of California, Berkeley with highest distinction, followed by his medical degree at the University of California, San Diego, where he also completed his residency in internal medicine and fellowship in infectious diseases. Since joining Olive View UCLA in 2003, he's played a key role in advancing AMS, infection control and clinical research within a major academic safety net health system. His work focuses on antimicrobial resistance, diagnostic innovations, and stewardship strategies to optimise antibiotic use. Professor Jeng is an active educator, researcher, and invited international speaker with numerous peer-reviewed publications and presentations addressing infectious diseases and antimicrobial stewardship. Thank you, Arthur.
Thank you so much. So I'm here to give a little bit of a quick lecture on advancing antimicrobial stewardship perspectives from the USA. Now, when I say USA, of course, in the United States, the healthcare delivery system is quite different than I would say many parts of the world, in that it's at the moment still primarily an insurance sort of based system. And so patients have varying levels of insurance. Some patients have good insurance, some patients don't have insurance. And so lots of the hospitals are fee for service. But so when I say USA, really, I'm going to give an experience from my hospital, which is Olive UCLA Medical Center. And my hospital is actually a safety net hospital for our city in Los Angeles. So we are taking care of the patients without insurance and or have publicly funded insurances. And so in that sense, it's actually much more similar, I think, to here in Australia, as well as the much of Asia as well. Advance it. So there is, however, in the US law or bill that requires all acute care hospitals to have AMVAC stewardship and to show our efforts and progress to peer-reviewed committees. And, you know, of course, the entire purpose of that is to help stem the tide of resistance and to optimize patient outcomes. It is also, every single hospital in the United States is also reviewed by the Joint Commissions for the Accreditation of Healthcare Organizations, or JCO we call that. This organization can actually shut down hospitals, so it's quite important for all the hospitals to pass their review. And so therefore, at least on paper anyways, all the hospitals in the United States have stewardship programs. It's just that, as I mentioned earlier, it's quite variably practiced. So within the UCLA system of hospitals, for our infectious disease fellow trainees, they rotate through 5 hospitals. So there's the Ronald Reagan UCLA Hospital in Westwood, there's the Santa Monica UCLA, there's the Veterans Hospital, there's our hospital, all of UCLA, and then there's Cedars-Sinai. In those hospitals, much of those are going to be sort of fee-for-service type hospitals. And so you can imagine in those hospitals, stewardship is not really top on the priority for those hospitals. Our hospital being a more safety net hospital, then we put stewardship as one of our main priorities in regards to antibiotic usage. And so again, that's why I'm going to be sharing our perspective on that. We will, we sort of, in terms of our efforts in stewardship, sort of go along our published Infectious Disease Site America guidelines, of which there have been 2. And, you know, I'm just showing, again, just a quick snippet of what we do, but you know, you might see on the bottom in these slides some of the bullet points from our guidelines. Ideally, in terms of stewardship in the US, there's 4 main components. One is the ID physician, who's going to be the director of AMVAC stewardship. This is the part that in many hospitals in the US actually isn't always there. Like they'll have a figurehead or somebody that they name as the physician steward, but most of the times in most hospitals, that doctor is really seeing patients and giving consultations for ID, but not really focusing on stewardship. Again, in hospitals like ours, and myself, I spent a lot of my duties in AMVAC stewardship on rounds with stewardship. Most hospitals, almost all hospitals in the United States will have an ID pharmacist, however, and that's going to be the sort of the key cog in running a lot of the stewardship endeavors. The microbiology department is also really key because they're the ones that are going to be helping us with the diagnostics. And, without diagnostics, we really can't do much in stewardship. And rapid diagnostics, as I'll touch upon a little bit later, is something that can allow us to do our stewardship interventions in a much earlier fashion. And then lastly, the infection control specialists who are going to help us stem this spread of resistance. And so as I think everybody who does stewardship know, one of the most important aspects in stewardship is listed in this slide and in our guidelines: prospective audit and feedback to the prescriber in regards to whether the antibiotics that they're doing is appropriate, not appropriate, or optimal. And this has been supported by A1 level of evidence, and it can be done by the ID pharmacist or the physician. It used to be that when people did these sorts of audits and feedback to the prescriber, it was kind of like, please do this, don't do that type of thing. But really the purpose of this though, is to provide education to the prescriber. That's really the underlying goal, because if you just tell the provider, use this antibiotic, don't use that antibiotic, and they may or may not accept that recommendation, if they don't really understand why they're doing the change, then the next time they see the same patient with the same diagnosis, they may not change their practice. The point is, the purpose of this is to try and really get the education to the provider to understand why the recommendation is being given. And so utilizing early on, these were just done by sort of phone calls to the prescriber and verbally being told what to do on the phone, right? So some years ago, we decided to try putting these recommendations into notes. And there was some pushback, and at least in the United States, to do that because of some medical legal concerns and everything. But we decided to pilot that in our hospital this some years ago. And this would be an example of where we do a note, right? And in these notes, what we try to reflect is that this is not just we look at the antibiotic that they're using and then look at the diagnosis they put in and yes or no type of situation, which many providers will say, well, you don't really know what's going on in that situation, right? You don't have a full picture. Right, so we're not going to listen to your recommendation, right? If you look at this note, you'll see that the HPI, the physical exam is documented by the providers, the labs, radiographs, microbiology, all on there. What's really just missing, of course, is the physical exam, which the stewards don't do. But listening to the lungs and seeing the report on the radiographs and the X-ray, does that really change the recommendation? Well, for the most part, not. We do tell the teams that if they want to escalate to a full ID consult, then please do so. Rarely, though, if ever, I'll say, is the actual antibiotic recommendations change just because you get the consult. So, we actually presented our experience with this in one of our annual conferences. This is, again, some years ago when this was not as commonly done. And we did show that the institution of these notes really brought down the usage of antibiotics that we're looking at. And then when we sent out surveys to the residents, asking them, do these notes stimulate ID-related reassessments, influence their antimicrobial prescribing, and provide education? Most of them said yes. Nowadays, I think the sort of a practice in regards to notes is more widely used in most hospitals. Another thing that our hospital does a lot of is formulary restrictions. And we do have these pre-authorized indications where if you do have a acceptable diagnosis, that you can get the restricted antibiotics. This is kind of an example of what ours looks like. And so you can see that, for example, some of these antipseudomodals like cefepime peptazo and Vanco, there's pre-approved indications if you were able to indicate that in the orders. And in the Cerner system, anyways, this is kind of what it looks like, So in this case, if you could click on the indication there, probiotic neutropenia, for example, for cefepime, then it'll be approved automatically. If you're indicating something that is not pre-approved, then this is where you need to contact the Antimicrobial Stewardship team and then get the name of the approver in order to get the antibiotic itself. Also in our guidelines, there's high recommendations for giving empiric recommendations. And so, we had done a lot of effort, putting a lot of effort into this. So, we had come out with these foldable cards for our all of the learners in our hospital for all the common infections that you see on the left-hand side there, right? And then we list the likely pathogens and, of course, the antibiotics that we recommend based on both evidence-based guidelines as well as our local antibiotic resistance risk, and also the stewardship goals that we're trying to achieve. And then there's commentary there afterwards. We also created a sort of a badge buddy, so that because we found that these cards that you see here can be lost amongst the learners, and so we created a badge buddy that could just click onto their batch, but hopefully don't lose that. Of course, you could by necessity, this has to be much shorter, right? So you can see that it just has only the recommended antibiotics and not really the other information that we have on the card. One of the things that we try to do, at least in our system of hospitals, is to extend out the life of carbapenems. I think in some parts of the world, there's a ton of carbapenem resistance, and I think in the United States, anyways, it's getting up there because people use a lot of carbapenem, so because that's kind of one of the antibiotics that people use for ESBL type infections, right? So one of the major efforts that we try to do is to try and come up with strategies to decrease carbapenem usage. And so what we did to do that, though, was we actually sent out a massive survey to all the residents, asking them, when are you guys asking for carbapenems and why? Which bacteria you're trying to cover? And what we found most commonly in these surveys that we sent out was that UTI was by far the most common diagnosis that residents were indicating why they wanted to use carbapenem because of the fear of ESBLs. So we developed an algorithm to try and decrease carbapenem consumption. It goes like this. So if you see somebody with a UTI, you ask the normal questions you would normally ask to see if they are at risk for having ESBL, recent antibiotic use, following hospitalization recently in nursing home resident, presence of a coronary catheter, ICU level. If you're ICU level, even without any of the above, I think qualify as well. And then we ask whether the patient has a cystitis or a pyelo, something that's just localized to the bladder, or pyelonephritis, because two oral agents that we have available, and I'm sure you have these also here in Australia as well, nitrofurantoin and fosfomycin, we have 90% susceptibilities with ESBL. So a very, very good oral agent to use for cystitis. In the US, unfortunately, we don't have fosfomycin in the intravenous form that I know is available around the rest of the world. We only have it in the oral form. So this particular antibiotic is only approved in the United States for the treatment of bladder infections. So if you do have a bladder infection, though, with either suspected or proven ESBL, these are the drugs we would recommend. If you don't have any of the above, then on IC level, then we would still recommend a cephalosporin type antibiotic, like third-gen cephalosporin, for example. But if you do have one of these risk factors and or prior cultures growing on ESBL, then actually the antibiotic class that we were recommending is an imiglycoside. We recommend amikacin because of the highest barrier resistance in that particular setting. And then we can look at the culture results if it's an ESBL, and if it's not, we can go back to a cephalosporin, maybe one of the quinolones or sulfos for if it's susceptible. And if it is, then we'll continue on the imiglycoside. This sort of one of the exclusion criteria here would be if the patient is having poor renal function, then maybe not go through this pathway. It was probably use a carbapenem in that situation. And that's mainly because people with poor renal function, if their renal function gets worse the next day, it's hard not to blame the imiglycoside if that's the case, even though I think historically we know that 1 or 2 doses of imiglycoside doesn't tend to cause kidney injury. So we actually just, by the way, presented our experience with this in our annual national conference, ID Week, in Atlanta last year. And we basically looked at all the patients that got treated with either carbapenem or imiglycoside from years 19 through 2023. And we actually found that the success rates for imiglycoside-based therapies was no different than that of carbapenem. It's actually a little bit on the favorable side for the imiglycoside. Looking at the secondary outcomes in regards to side effects, C. diff rates, we saw some with carbapenems, but not with imiglycosides. Imiglycosides don't tend to alter your stool flora. That's one of the bonuses of that sort of class of antibiotics. AKI was actually higher with the carbapenems, not because carbapenems injure the kidneys necessarily, but because, remember, the patients that were already coming in with kidney injury went on carbapenem. And very, very low rates of AKI when you're just giving, say, 5 to 7 days of imiglycoside in the select patients that we used it in. So this is what we just presented. Of course, one of the key concepts in stewardship was de-escalation when we tried to eliminate or hone in, narrow the spectrum of antibiotics based on the culture results, right? What we identify as the pathogens. But the barriers of de-escalation is that can you identify the electric pathogen, and when can you do it? Ideally, you do it in an earlier part of the admission in a timely fashion when we really need the antibiotics to be more optimized. We can get gram stains, for example, with blood cultures and sputum cultures, but gram stains kind of give only some limited information and may not tell you exactly what you're dealing with. So, here's just an example where historically people are getting blood cultures, and if you get the blood cultures and it signals that something's growing, you get the gram stain. The gram stain tells you whether it's gram-positive cocci, gram-negative rod, but you don't really know what it is yet. So usually what happens is you continue your empiric antibiotics, even though you get the gram stain, even though the blood culture is showing something, maybe even escalate because of gram-positive cocci clusters. You don't know if it's a methicillin-resistant strain or not. And so you don't get the actual identification of susceptibilities till about day 3 or so usually. So that's standard conventional way we manage blood cultures. But nowadays with the multiplex PCRs that we have nowadays, and this is just an example of one, and all the targets that the PCRs can identify, and they can usually identify this in an hour or so with high sensitivity and specificity. Now the paradigm changes that when the blood culture is signaling positive and you get the gram stain, you run it through the PCR, and then in an hour, you actually find out what it is. So instead of waiting till day 3 or 2 or 3 to figure out what it is. And so one of the main bonuses of this is, I'm going to give an example of, say, when you see gram-positive cocci clusters. So if a patient has blood cultures going gram-positive cocci clusters, is it MSSA, is it MRSA, or is it just a contaminant with a coagulative staph? Well, historically, if you didn't know what it was and you're worried about the patient, then you probably just institute some sort of anti-MRSA antibiotic, right? And then 40 to 70 hours, you get the result, whether it's MSSA, MRSA, or coagulative staph, and then you can adjust your antibiotics. Well, then that means a lot of people are getting the anti-MRSA antibiotic because most common cause of gram-positive cocci cluster is a contaminant, coagulative staph. But if you can do the multiplex PCR in about 60 minutes, if it's coagulative staph, well, then you don't have to do anything. You could do nothing, give no antibiotics, unless you're suspecting coagulative staph is real, like having a central line or prosthetic valve, perhaps, right? If it's MSSA, there's no need to expose the patient to vancomycin, potentially a nephrotoxic drug, and give some anti-MSSA therapy, like a cephalosporin or maybe a semi-synthetic penicillin. And then only if it's MRSA would you need to give an MRSA antibiotic. So this sort of I think, one of the potential advantages of doing these multiplex PCRs. All the studies, though, on these multiplex PCRs have shown, though, that just giving the result by itself doesn't seem to do too much in regards to the behavior of the antibiotic prescription. So really it should be ideally paired with antibiotic stewardship. And again, these notes that we leave, so therefore we leave these notes in the computer system to help with that. And here's an example where the PCR system has already identified coagulative staph in the blood, but the team did not recognize that it was coagulative staph in the blood and had the patient on vancomycin still. So here's where we try to explain the interpretation of what's going on. And again, without a line or prosthetic valve, you don't need to worry about it. Fortunately, these multiplex PCRs nowadays are available not just in blood, but in many other compartments of the body, including CSF, the nasopharyngeal compartment, sputum, stool, GI, and stool as well. I want to give a quick example of a recent case that we saw. This is a 44-year-old woman. She has diabetes, came to the ED for a week, cough, shortness, breath, and fever, worse in the last day. In the ED, her OG stat was 70%. On Romero, she rapidly escalated to become intubated. She was hypotensive, rapidly went on 3 vasopressors. So she was in septic shock and then severe sepsis. Her blood work showed actually leukopenia with a lot of bands. Her ABG showed a pH of 7.09. Her nasopharyngeal swab for viruses, influenza, RSV, and COVID were all negative. This was a chest X-ray, multifocal infiltrates. Some of them look kind of mass-like. Here's the CT scan of the lungs. She went to renal failure. Granny went to 2.6. Her blood culture was showing 2 out of 4 GPCs within 24 hours. The ICU and the sputum gram stain had gram-positive cocci. The ICU team had put this patient on vanco, cefepime, and zithromycin, and tuberculosis therapy. So actually on 7 drugs. So we sent the multiplex PCR on the sputum, and the blood was already being run, and they all showed MSSA. And the sputum, as you see, also showed influenza as well. So this is actually the textbook case of somebody getting influenza with a superinfection with Staph aureus, doesn't need these 7 antibiotics that the patient is on. So we had then recommended at that point in time to change the antibiotic to a semi-synthetic penicillin, which loxacillin, and also tamivir, which of course the patient wasn't on influenza therapy. And it was, very scary for the ICU team to do that because this patient was on 3 vasopressors and acutely ill and really imminently at the risk of dying. But it took, I would say, 4 hours or so to convince the ICU attending about the technology. Because one of the questions that she kept on asking was, well, what if there is something that the PCR is not detecting, for example? I said, and when we were asking, well, which bacteria are you worried about that the PCR is not going to detect? And she kept on saying Pseudomonas, but Pseudomonas is on the panel, so that's not the bacteria you have to worry about. So the advent of all these newer sort of diagnostics, I think something that faculty as well as the residents and learners are not quite as familiar with, right? So we offer a lot of these resources in our computer system that I'm just going to show you some examples of here, where the resident or whatnot can just click on various links as you see here. For example, they can go to the blood culture systems and see what the PCRs can detect and cannot detect. And if you scroll down, empiric antibiotic recommendations, a very common question that people have is, duration antibiotics. And so here's on duration. This is all based on evidence-based medicine literature. When we instituted the GI panel, one of the biggest questions is, if you get, for example, enteropathogenic E. coli, what do you do with that? And so again, we have the resources to have them just click on this and scroll down and see what to do based on, and you can see many of the E. colis do not recommend empiric treatment. And then, some of the things that we adopted more recently, having in the Cerner EMR system, doing a urine analysis with urine culture reflex. In other words, you can only get the culture if there's greater than 10 white cells. It's quite fascinating that when I ask residents, how do you diagnose UTI? The most common answer that I get is if I see bacteria on the urine analysis. So that's not how you diagnose UTI. You just look at the white cells, and so that's what the computer system is looking at as well. There's C. diff testing restrictions, prior authorization pop-ups for using carbapenems, meaning there's all these checkboxes you need to check off for saying we're worried about ESBL, for example. And then we can, and for diagnostic stewardship, can block the ordering for blood cultures within 72 hours. And of course, as with all stewardship programs, we monitor the usage of antibiotics and also the outcomes. Here you can show we show the drop in the rates of resistance based on the lowering of the usage of anti-pseudomonal drugs. And we're actually one of the, I think, few residency programs in the United States that offer antibiotic stewardship educational elective. I think Washington University in St. Louis is another one. It's offered to both the internal medicine residents and also in the infectious disease fellows at UCLA in the stewardship program. Elective, I should say, there's didactics on both stewardship as well as antibiotics, bacterial resistance, indication for various anti-pseudomonal and MRSA drugs, when prophylaxis can and can't work, things like that. And then they also spend time with the ID pharmacist on the hands-on time with the pharmacist on the prospective audits, writing the notes that I had showed you as well. So they have, and their own experience. And I feel that the residents that go through it, when they see the notes subsequently from there on the ward side of things, really understand what the purpose of these notes and what the meaning of it is better. We do formal rounds with people on this, not necessarily ICU, but we do formal rounds in the wards. And really, we found that's one of the our top elective, along with the procedure service. I'll share with you guys. I think my time's up.
Thanks, Arthur. I'll just check. So we do have a Q&A functionality with this Zoom if anyone would like to put some questions through. We'll move on to Kaz's presentation, but we've allowed for enough time at the end of both talks for a bit more of a discussion. So, well, for formality's sake, for those that don't know Kaz, Kaz is our director here at the National Centre for Antimicrobial Stewardship and the director of the Royal Melbourne Hospital Guidance Group, and the Associate Director of Health Services Research and Implementation Science at Peter Mac, and a Principal Fellow at both the Department of Medicine and Oncology at the University of Melbourne. Kaz is a nationally and internationally recognised leader in AMS and health services research. Her foundation of the Guidance Clinical Decision Support software is now implemented in hospitals across Australia and co-leads the development and delivery of the NAPS program, a cornerstone of the AURA surveillance program. Her work has directly influenced national AMS policies, accreditation standards and clinical practice, all while building workforce capacity across human and animal health through a One Health lens. Kaz will be providing a status update on AMS in Australia. Thank you, Kaz.
Thanks, Court. And great to hear your talk. I mean, I guess all of those things that you do, we also do. So I'm not going to go back and go through in particular, but I guess Australia has been ahead of the pack a little bit in terms of building out the data infrastructures required to support our stewardship programs. And also we've had the opportunity to move into more of a One Health lens. So the NCAS, the National Centre, has been funded for over 10 years now through consecutive grants. And we are very fortunate that we have collaborations with other universities around Australia and with various stripes of researchers and clinicians from primary care, aged care, and our veterinary colleagues as well. And that has allowed us to take a very high-level systems approach as how we see stewardship, particularly with the global challenge that we face. I'm not talking about it today in particular, but those who know me know that I really see antimicrobial stewardship primarily about patient safety rather than AMR. Because I think if we lose sight of the fact that all prescribing occurs because of the concern about animal or patient safety, we lose sight of how we're actually going to deliver behavioural change to make them prescribe better. Obviously, optimal prescribing is required to minimise the emergence of AMR, but those who know me know that I don't sit around focusing on AMR as a primary driver for AMS. And so NCAS's research questions over the years has really tried to focus on, well, what is good prescribing? You know, how do we measure good prescribing? You know, we know measuring simply consumption is old hat. It doesn't provide the nuances that were required to understand why an antibiotic is prescribed. What is the best practice framework? What fits into workflows, and what interventions actually work. And so you see the yellow boxes are really where we're focusing now in terms of moving on to design best practice stewardship programs. Obviously, you can see there's the lots of blue, the lots of stuff that we've done in the hospital sector. And Australia, I think, really has built in a very good framework around AMS, obviously doing a lot of the stuff that you're doing, but also moving forward. The other thing which I always talk about is changing the way we do things. We can no longer rely on long, clinical trial, other standard sort of quality improvement activities to drive our evidence base for what we do. And so we need to be thinking in a systems way, and we explicitly endorse the learning health systems approach. This was established in the US by Charles Friedman. You will hear it talked a lot about now. Governments are sort of cottoning onto this concept. But really, it's making sure that if we're going to be doing something to optimise our stewardship program, we need to ensure that all the key stakeholders, including our consumers, our end users, are central to that design. And for our group, we have explicitly focused on the fact that we need to understand and optimise the data from our EMRs in particular, understanding indications for use, because indications for use are the main way to understand why an antibiotic is used and for what purpose. And generation of appropriateness metrics is more relevant to drive how we develop guidelines, decision support, and pathways of care, as well as making sure that we have that data in place to demonstrate cost effectiveness, return on investment. And all of this requires different ways of doing research, which I'll talk about. And really, we are now explicitly recommending that if you are going to be actually developing new models of care, there are other stripes of people. AMS services are often, just like yours, very, very minimally funded for what we need to do. And we know that many of these experts, the implementation scientists, human factors experts, social scientists, communications, they're not readily at hand for most hospitals trying to do thanks God, that are trying to develop new models of care. But certainly it is something that you should be thinking about, particularly if you're going to be doing something at scale. We had the opportunity to be invited to do a systems review of global antimicrobial stewardship programs. This is published in Nature Microbiology Reviews in February, and Court was one of the co-authors. And I really like Rod pulled together a bit of a heat map on where the current evidence lies in terms of AMS and where it sits in terms of the other sectors. And obviously, you will agree, Arthur, that obviously policy is a major driver of AMS programs, and yet there's a lot less evidence about some of the other things that we're actually doing. And some of that relates to the fact that how these studies have been designed, the outcomes that have been presented. And it's important for us to recognise, if we are going to be demonstrating efficacy of programs, to think about some of these other measures. And you can see the absence of some of those in areas. So I'm not talking about primary care specifically, but antimicrobial stewardship per se is an optional area for accreditation in primary care. There's no mandatory requirement. They are measured against what we call in Australia the clinical care standards, which were developed by the Australian Commission, which is sort of 8 quality statements around antibiotic prescribing, and they've been developed for both the prescriber as well as for the patient. So what should a patient expect if they're given an antimicrobial? These clinical care standards are mandated, however, inside our hospitals. So while we have a really nice set of national framework accreditation, it is not mandatory outside of the hospital sector. And so when we look at the evidence base, not surprisingly, as you mentioned, there's very strong evidence for prospective audit and feedback, and quite strong evidence for pre-authorisation and decision support systems. IVR switch is a major program, particularly for most of us now, because we know that for AMS, most AMS services, if you look at the interventions in our hands, in the similar program to yours, 2/3 of AMS interventions will lead to IVR switch stopping or shortening. That directly influences patient length of stay, and we've been able to demonstrate certainly cost effectiveness by having prospective audit and feedback. You can see the big gaps in other areas such as aged care, primary care and animal health, of course. And part of the challenges in those sectors is they don't have the benefit of in-house quality use of medicine staff, for example, our pharmacists. Although in Australia, we now have limited funding for quality use of medicines pharmacists to come into the aged care sector, and it's an active area of research for our team to understand how you would develop up an AMS program in the aged care environment. And then finally, outcome measures, again, really a lot of evidence around consumption, much less evidence about the impact on AMR. However, we do know that there are good studies to show that if there's good IPC and good AMR, then there's, especially in the hospital sector, you will see significant impact on both resistance and emergence of C. diff. We don't spend a lot of time focusing on cost savings, but I would encourage you to think about systems-wide cost savings rather than just drug or individual impacts. I think that's actually really important. The other thing is to consider, what are the drivers and enablers? And I think in Australia, it's fair to say that, and I'll show you our accreditation framework in a minute, that has been the single biggest driver for what has happened in Australia in terms of building out the skill sets, programs and activities that our stewardship programs do. But it is really important to think about what the drivers are, and the setup, as you say, of our healthcare system directly influences what can be done. So Australia, our hospitals are funded through the states, whereas our aged care, primary care are funded through Commonwealth. There are this separate governance and funding of primary care and aged care versus hospitals has really led to a very different approach to how things have been able to play out. So for us in Victoria, for example, we need to make sure that stewardship programs over years and years and years have really struggled to put up business cases to get funding. Our CEOs are interested in reducing activity costs. It's not the driver to develop quality use of medicines program is not always a driver for our CEOs in a very restrained funding environment. And it's probably even worse at a Commonwealth level. So it is funding and models of funding are inherently a major challenge for all AMS programs across the country. So this is our current stewardship framework, and this is a second version of it. You can see it's actually very detailed. And this, as a lot of the activities here have been directly informed by our work, dating right back to early 2000s when we were able to demonstrate the impact of our approvals program guidance and a couple of other approvals programs which directly impacted quality of prescribing and reduction of broad spectrum antimicrobials and total antimicrobial use, as well as our NAPS platform, which of course is now a key part of Australian stewardship. So the evidence base is that we need to have both pre-prescription and post-prescription activities for optimal efficacy. But you can see how our stewardship framework, accreditation framework, references appropriateness all the time. Now, appropriateness in the past, internationally, is often related to guideline compliance. We argue that that's not appropriate. We do measure it. Appropriateness is much more nuanced assessment that needs to consider all aspects of the prescription. And so coming to the NAPS platform, it is now in its, 12th year now, continuously funded either through research programs through Royal Melbourne Hospital and is also supported by the Australian CDC. It is free accessible to every hospital and aged care home in Australia, and it is a core part of or available tool that they can use to support their AMS programs locally, as well as the data that is de-identified, aggregated and supported to the national surveillance platform. So it's the same data that stewardship programs use on the ground as well as it goes into the national program. We have moved away from, in the past, from national, we would put up a national public report for the hospital, surgical and aged care programs. We've started to pivot away from these long 150-page technical reports that no one reads into more meaningful infographics that uses the NAPS data, that provides clinical vignettes and recommendations on how to prescribe. And there are particular indications, I'm sure you'd be the same in the States, where we know that there's sort of always poor prescribing. And the fact that users can actually have a real-time dashboard report the day that they actually finalise their audit and they can benchmark against like organisations is very important to our end users. And it has been continually improved over time with validation, structured approaches, e-learning. We have a help desk to support our particular remote regional sites. And we were very excited in the early days because we would have bush hospitals in, remote Western Australia calling us and saying, we didn't realise that we were doing that we needed to improve so much. We didn't realise our appropriateness was so low. We didn't realise we actually think that the NAPS has actually saved lives. So that was actually very exciting for us to have that. And obviously having a standardised approach has allowed us to pilot and scale and even culturally adapt. So we've had Carlos Palos, one of my PhD fellows in Portugal, did a cultural and linguistic adaptation of the NAPS in Portugal, because obviously, for programs like this, particularly when you talk about clinical indications and defining that appropriateness questions, it needs to be culturally adapted. So over the years, we have developed a number of modules, the hospitals, aged care, surgical surgical prescribing is the most common indication for prescribing, probably is for you as well. It's often under the radar, and the surgical naps is a major focus for particularly in the private sector. So we have both public and private contributing. And then more recently, we have developed the antifungal naps. Antifungal prescribing is more complex than antibiotic prescribing. It often happens over a number of months. Patients cycle through requirements for empiric, directed. They might require primary and secondary prophylaxis. The patient's status changes over time. And so we look at it in more of a longitudinal evaluation of quality of prescribing rather than a single point prevalence approach that we do, for example, in the hospital nap. So it's much more nuanced. We've continued to build participation in Australia. This is just the hospital naps, and many hospitals are continued. Many hospitals will participate over a number of years, either doing the hospital or the surgical naps. And now the NAPS platform itself also supports what we call deep dive audits or focused audits. These focus audits allow hospitals who already understand their general overview of prescribing to focus in on a particular indication. So they might do a focused directed audit on communicable pneumonia or some other indication. They can do consecutive cohorts evaluation, look at guideline concordance, appropriateness. They can understand who is doing what and where. And a great example of that was years ago at the Royal Melbourne Hospital. We had in our consumption data started to see a big rise in meropenem use, which is sort of out of the blue. We went in and did a deep dive audit using the NAPS of meropenem. And as you say, quite rightly pointed out, a lot of it was driven by fear of ESBL. We could see that a lot of that was happening in particular areas like haematology, and also in the urology service. We were able to understand what were the indications they're using meropenem for, where we could re-educate them on when you need to use meropenem and alternative agents, and that actually then led to that immediate decline. So understanding consumption and then deep diving and having a standardised approach is really important. So Kaz Chen, who is leading our NAPS redesign at the moment, one of our PhD fellows here, is over in ECMID and presented this data. It's also in process in publication. But what's important here is, which is probably the first time it's ever been shown, but if you have a program supporting audit and feedback and surveillance of appropriateness, and you have continual or consecutive or ongoing participation, we've been able to demonstrate that you continue to show continued appropriateness of prescribing. Appropriateness of prescribing is associated with improved patient outcomes. So this is very exciting data for us because we know that many of our sites continue to participate, and this had fixed effects, including remoteness, etc., surgical use, participation. You can see here that we've always known Australian hospital. We have around 750 public hospitals. We have about 20 principal referral hospitals, and then we have hospitals classified as A, B, C, D, E, right down to, and also specialist hospitals. We've been able to see very clearly that appropriateness is highest for the principal referral and specialty hospitals, up around 80 to 90%, down to our small rural regional hospitals where appropriateness can drop down to between 60 and 70%. So this partially relates to the fact that these smaller hospitals don't have access to, microbiology services, expert infectious diseases services and expert AMS services to help to optimise their prescribing. So that's a really important driver. We also saw broader range of effect, but we've also seen pleasingly seeing some shift in private hospitals. In Australia, private hospitals are very much driven by elective surgery. So many of our private hospitals do regular surgical prescribing audits. The interesting thing to note is that despite COVID, we didn't see a reduction in participation in the NAPS, which is actually really important. This is probably also no surprise to you, but we see this continuously every year when we look at the NAPS. We see that there are some particular indications where we really need to focus, and two of those are surgical prophylaxis and COAD. We regularly see those indications where there are very clear guidelines and protocols, such as prosthetic joint infections, sepsis, and endocarditis, for example. These typically have quite high rates of appropriateness, and we think it's probably because they tend to be sicker patients. There's more oversight. To hone in again on why we choose appropriateness over guideline concordance, you can see very clearly here that while Australia's had therapeutic or antimicrobial guidelines, national antimicrobial guidelines available since 1978, I do believe we're the only country in the world that has such a comprehensive suite of antibiotic guidelines that cover pretty much everything, including antifungals and antivirals, continuously being updated through our therapeutic guideline colleagues and accessible to all public hospital doctors. We know that patients are often complex, particularly immunosuppressed patients, and often there are multiple reasons why the guideline is not fully concordant, but we know that using an appropriateness assessment matrix is much more fit for purpose, and we always see a 10 to 15% difference in concordance and appropriateness. The other thing to say is that when we do talk about prescribing for our end users, they really like the term appropriateness because it's much more meaningful than you're not guideline concordant, because they'll immediately say our patients are complex. So right now we're in a full redesign phase for NAPS. It is being built to bring all the modules together to be in a single platform, particularly optimising the auditing workflows, decision-making, business intelligence reporting frameworks. It's a very exciting time for us, and I think we'll be due to launch sometime in May, Court, for the hospital, isn't it? So we're busy getting ready for the new relaunch. The other point to make, and this is really important, is that our end users, our stewardship programs, want to see triangulated data. It's not just consumption appropriateness, but what is the impact on AMR? This is a very nice graphic comparing our NAPS appropriateness with consumption, and these were only hospitals that are participating in both programs in 2022. But I'd like to point out in the light blue columns that you can see that fluoroquinolones, glycopeptides and carbapenems, these have always been the target of AMS programs. These are our so-called restricted antimicrobials. They've been prescribed at quite high concordance and appropriateness rates, but their actual usage is quite low. So the intended purpose of AMS is successful. What is more of an issue is the under the radar. In the green, you can see very high rates of beta-lactamase inhibitors. These are the augmentins, Keflex. We've got a national epidemic in Keflex prescribing. This is where you see, up to 1 in 3 prescriptions that are inappropriate. That is all under the radar. That is happening in our hospital, it's happening in our aged care, and it's definitely happening in primary care. We have industrial rates of Keflex prescribing for anything that for skin, chest, urine. Most of those are non-guideline compliant. So I think that's really important for us to consider. Bit of a busy slide. I asked Claude to make a slide for me. It's quite helpful, really, but really pulling together the messages around surgical prescribing. the bottom line is that we have lots of work to do with surgical prescribing. The SNAPS is another voluntary program. It tends to be done by units focusing on particular groups or particular types, particular craft groups or particular surgeries, but you can see that we have usage across all the surgical craft groups. And generally you can see that there's very significant room for improvement. Perioperative is a bit better, but really we're having major issues with post-surgical prescribing, extended durations of antimicrobials, and this will be a very major target of NCAS's current research work that Courtney is going to be leading. And there are some groups that are more well-behaved than others, but it's a major challenge. Australia is also leading the world in allergy delabeling, and this has been a huge progression and very impressive piece of work from Jason Trebbiano, who is the director of the Department of ID here, and was one of my original PhD fellows. But he's done a huge amount of work developing the PENFAST rule. It even made it into the PIT in one of the episodes of the PIT. Over the bedside, done the PENFAST rule. He's very excited about it. He even did a TikTok actually about it. He was so excited. But anyway, this very simple bedside rule has really changed the face of allergy delabeling, because it's provided a simple tool that allows immediate delabeling, as well as a pathway through to formal skin prick testing delabeling that he runs a couple of clinics in Melbourne. But really upskilling pharmacists and clinicians to do this work, and even nurses do this work, is really going to change the face. And the reason why it's important is that we have shown in the NAPS data that 1 in 5 patients in Australia in hospitals have an allergy label. The minute you have a penicillin allergy label, what do you get given? You get given ceftriaxone, you get given vancomycin, you get given quinolones. So he's been able to demonstrate that delabeling not only reduces broad spectrum prescribing, it actually improves patient outcome and reduction of AMR. So this is very exciting work, and it's just amazing. He collaborates very strongly with Elizabeth Phillips at the Vanderbilt. So I know he has colleagues in North America that are also scaling the work. My last few comments relate to digital stewardship. And Arthur, you were saying your hospital has Cerner. We're an Epic site. We have a combination of Cerner and Epic Victoria. There is no hospital with an EMR that is not struggling with digital stewardship. There isn't, because the trouble is we are drowning in data, starving for knowledge, for action. And a lot of what we do is trying to get the data in a meaningful way to understand what to do, whether it's retrospective audits or day-to-day work. And the reason why I've got the iceberg there and all those other graphs all around is that when we're looking at prescribing behaviours, a lot of under the radar comes down to, prescriber preferences, their own belief systems, patients' belief systems. And while we can sort of functionally do rounds and things like that, there's the challenge of changing behaviour and building out clinical pathways to drive better prescribing, whether it's decision support, using AI. We have to factor in the fact that a lot of prescribing is not only under the radar, but relates to behavioural and qualitative issues that we're not actually always looking at. So here at Royal Melbourne Hospital, we led the development of the first sort of scaled decision support system called Guidance. It was first implemented at Royal Melbourne in 2005, and it's gone through a number of digital iterations. It's been here in the precinct for a long time, Peter MacCallum Royal Melbourne. But really it was our mission was to consider AMS as requiring a systems approach. So you were talking about the things that you have in UCLA, such as formulary restrictions and approved indications. So we have taken that piece around what are the formulary, what are the approved indications, what decision support does an end user require to choose the right indication, what information needs to be transmitted to the AMS team to allow them to triage which patients to see when 50 to 60% of our patients are on antibiotics. ID only see a small proportion. Therefore, the AMS team somehow has to be able to look across the entire organisation to say, okay, I've got 3.5 hours or 4 hours of stewardship physician time this week. Who am I going to review? The rest of the time, we're relying on decision support to ensure that prescribing is appropriate for the other patients, and then how can we build out the appropriate reports to support audit and feedback and reporting to managers. So this has been something which is an iterative process, and we know that it has been very effective. One of our key groups has been the South East Sydney group, which guidance has been in continuous use since I think 2010. And 10 or 12. It is integrated with Cerner there and has been in continuous use. And this showed that we were able to reduce not only total and restricted antimicrobials, but led to some improved patient outcomes. And it is interesting tracking evidence-based with digital AMS. Guidance has been one of those programs that's been incorporated in all the reviews over the various years. And we have a lot of experience in understanding not only the benefits, but also the significant challenges for having a program like this, which has to coexist with an EMR, particularly around interoperability. And so this, our current position right now is understanding, while we have established this program, which we know is very effective, even partially integrated with EMR, we are also thinking about, well, what are the challenges? And that's partly around two-way integration with a program like Epic, but also the opportunities that brings with the ability to be agile and develop new things. So right now, guidance is in 53 hospitals around the country, including some networks and statewide implementation. It's been around for 20 years. A lot of our focus has been, we made a conscious decision a few years ago to say, right, well, we know that focusing previously, the decision support kind of related to just restricted antimicrobials, but our end users said, well, we want decision support for at an indication level. So if we're going to prescribe for a patient with community-acquired pneumonia, what are the factors that we need to consider in terms of first, second, third line recommendations? How do we bring them to the national guidelines? So guidance provides decision support, as well as directly linking them through to the national guidelines at the point of care, which is really important. And we've also spent time, I've talked before about having data models that can be scaled nationally and internationally, which we're doing with the NAPS, but we have also spent time building out what we call a universal indications list, which is the key reasons for use of antimicrobials. And this universal indications list is also used in the NAPS. So hospitals that use guidance that generate those indications at the point of care will significantly be supported when they're doing automated NAPS programs in the future, or that sort of data flow. We are very focused on supporting that post-prescription review process, and naturally, being the NAPS group, have built in the NAPS appropriate assessments into post-prescription review, which means that the real-time reports that the team can develop very much align with the NAPS and significantly reduces that audit and feedback time and reporting. Our current AI research at the moment, we have a number of grants happening, is really trying to wrangle that data. How can we collect all that data from the EMR and use data science methodologies to ensure that we can meaningfully extract quality of prescribing, process measures, including indications, etc. And can we automate? It's an open question for us. Can we automate NAPS appropriateness? Can we significantly reduce the time of auditing that we know our long-suffering stewardship teams spend a lot of time doing every year? And also, what are the opportunities around AI, agentic AI? We also understand what it takes to bring a system out into clinical use, and we have a very comprehensive quality management system. So Steve Christoph here, he sits on the TGA committee for software as a medical device. We We have our in-house and offshore development team. We have a QMS platform to ensure that we meet all the requirements. This is an exhaustive process, but a very important one because we need to continue to maintain the quality and the trust of our users. Thanks, Court, for this slide. I keep bringing this one, but I think it's very true. And how do we come from our whole lot of data in Senate and Epic into sort of meaningful reporting? And so we're leading a cool program. We're using data from Epic over many years. We've already extracted it, so we do understand how to get data out of Epic in detail, the micro team there. Epic data, we've got many years of primary care data from the Patron Research Database. I think Ruby may or may not be on. I think she might be on, not sure. And also our veterinary colleagues in the Vet Compass program, which extracts email data from every veterinary practice in Australia. It's a 5-university program. And we're doing a common process amongst each of the groups to understand what are the indications of interest. Urinary tract is the first cab off the rank. What data is required to actually generate meaningful process measures so that we can then do machine learning? What are the opportunities around using more AI, such as large language models, agentic approaches, and how can we sort of align the outputs? Really, again, lifting our stewardship up into this more national level. I've talked about this over time because everyone wants to jump into AI and machine learning. We do know that many hospitals, including a lot of work out of the US, out of bodies such as Stanford, have done machine learning projects or machine learning programs. We see very few implemented into clinical practice. They totally perform well in a single institution around antibiotic selection optimization, prediction resistance, early diagnosis and decision support. They perform very well, but we don't see a lot of external validation and scaling to other sites. And so that's partly, it's very challenging. So our focus here in our team has been to understand that we, having well-labelled gold standard data sets, will allow us, when we do bring in more data science, and we have these fantastic gold standard data sets that we can test against our test the machine learning and other AI LLMs against. My last slide really is how we do things and comes back to that comment I made at the very start, where we can do a whole lot of stuff with data, but we can only effectively implement if we understand the human factors and implementation barriers and facilitators for implementing anything into clinical practice. And so NCAS, with our latest Centre for Research Excellence funding, has brought in experts such as digital health experts, implementation scientists and human factors experts to work across every one of our streams to make sure that we build in those methodologies to ensure that our interventions are effective and sustainable and cost effective as well. And it's no more, and when we talk about digital interventions, even more important. And we know from our colleagues at Stanford, Nigam Shah, that, the return on investment is challenging for AI. It always costs. So we think that if we take a system approach, yes, there's some fancy stuff that we can do, but there's also very sort of fundamental foundational work around creating data models, creating a systems approach to support not only the stewardships, but also stewards, but also our prescribers and our managers and our funders, whether it's hospital, state or national, to understand what's required to remove those barriers to effective stewardship programs, of which there are many. And so these are just, my last slide is really showing the sort of work that we're stepping into now. So we're going to be doing, leading some really exciting work for our surgery to look at surgical prescribing, and be kicking off at Royal Melbourne Hospital, and we're working with the head of surgery. what is an AMS framework that would be fit for purpose in our aged care homes. We're well on the way in dental AMS with Leanne Teo. We have an amazing team of vets who have been, as I say to them, coming up the back straight with AMS in companion vets. They've done an enormous amount of work. In fact, one of the vets, Laura Harderfeld, with Court, we're just presenting at ECMID an international consensus around what does appropriateness mean across all sectors. Again, bringing that sort of concept of appropriateness into One Health. And then finally, we're working with Dairy Australia. So part of that is trying to triangulate data from farms, farm databases. The farmers will have a database and the vets will have a database. It's pretty cool. So it's a whole sort of area of interest for us. It's taken a while to get that off the ground, but we're very excited. So I know that's a bit of a higher level, but at least it gives you a flavour of where Australia is in terms of really taking that kind of systems level to AMS now.
Thanks, Kaz. I'll stop my share.